reactions in your faces. I know you're a little saturated, but then again, when you're talking about the pituitary gland is actually one of the easiest topic in your physiology. No? In all the topics that you'll have in your physiology lecture, it's one of the easiest topic. I promised you. Okay? So, again, if you're talking about the pituitary gland, if you can still remember back in your anatomy, it's actually a pea-sized gland, again, located at a depression of your sphenoid bone known as your sella turcica. Okay? Now, if you can still actually also remember, it's directly connected to the hypothalamus. And if you'll see, since it's inside a depression, what happens is whenever there will be a tumor or enlargement in the pituitary gland, what do you think might happen? Or what do you think might be the most common clinical manifestation or subjective complaint of a patient with a pituitary tumor? Ano kaya pwede? Anybody? Can I hear from Paulo, Nino, Vispo? What do you think can be a manifestation of a patient with a pituitary tumor? Just by merely looking at the picture, what do you think might happen?
Enlarge po.
Yes, it will enlarge definitely because you're talking about tumor. So what will happen if that pituitary gland will enlarge? Ano kaya?
Hyperactivity po.
Hyperactivity. What else?
Doc, vision problems.
Yes. Vision problems, no? Simply because it's directly connected to the hypothalamus and malapit siya sa optic chiasm. Because the growth is limited by this space, what happens is it grows, no? And paano siya lalaki? Pataas. So it will compress on the optic chiasm, and definitely patients with pituitary tumor will always complain of vision problems. And we call it actually as your bitemporal hemianopsia. Okay? So if, for example, a patient comes into your clinic complaining of visual problems, yung bitemporal hemianopsia, it means to say that the temporal side of the vision is blind. Wala silang makita. Okay? So if for example, a patient will come into your clinic complaining of that, the first differential diagnosis that you have to think of is a problem in the pituitary gland. Okay? Syempre, again, since you're dealing with brain, no? Another common subjective complaint of patient is headache. So headache and bitemporal hemianopsia. Okay? If you can still remember, Dr. Valeria told you a while ago that there are two parts of your pituitary. You have the anterior pituitary part, which is the epithelial side, and you have the posterior pituitary, which is the neural side. Okay? Even if it's a pituitary gland as a whole, and you call it as hypophysis, the embryonic origin is different. No? Anterior is different from the posterior. The reason why anterior is more of the epithelial cell because it came from the invagination of your pharyngeal epithelium known as your Rathke's pouch, while for your posterior epithelium or posterior pituitary gland, it is also known as your neurohypophysis, meaning to say the neural side because it came from the neural tissue outgrowth coming from the hypothalamus. Okay, so embryonic origin is different. Now, again, you have 6 different anterior pituitary hormone. Okay, you have your growth hormone, ACTH or TSH or prolactin, and 2 gonadotropic hormone known as your FSH and your LH. Okay, kaya 6, kasi 2, 3, 4, 5, 6. Okay, when you're talking about the different types of hormones, I will not discuss to you each in details because in your subsequent lecture, that is the time that will discuss to you as a whole. Okay, some of the pituitary hormones that I will discuss will just be on the tip of the iceberg. But I will deal more of the growth hormone, your prolactin, and your 2 posterior pituitary hormone known as your ADH or your vasopressin and your oxytocin. Okay? Maliwanag pa tayo doon? So again, 6 from your adenohypophysis and 2 from your posterior pituitary hormone. Okay. So I think this was also discussed to you a while ago by Dr. Valerio. You have two major types of cells coming from the anterior pituitary. Again, your adenohypophysis is the epithelial side of the pituitary. So as the different types of epithelial cells that you'll see under the microscope are the ones that actually synthesizes the hormone. Okay? So it's furtherly subdivided into an acidophilic cell and basophilic cell. Okay? Acidophilic cells simply because they stain red under the microscope under histology, and basophilic cell because they stain blue under the slides or under the microscope. And if you'll see, most of the cells are made up of acidophilic cells. 80% of the cells coming from the anterior pituitary are of that acidophilic type. And they are divided into either somatotropes or lactotropes. Meaning to say, somatotropes is the one, again, that secretes for your synthesizes the hormone, growth hormone, and your lactotropes synthesizes your hormone prolactin. While for your basophilic cell, you have your gonadotropes, which made up of 20% ng basophilic cell nyo, and that is the one that secretes your ACTH and LH, and the most least cell are your thyrotropes. 5% only of your basophilic cell. Okay? Now, again, this is just a slide showing to you the different types of cells that synthesizes the different hormones from the anterior pituitary. Okay? Now, when you're talking about the posterior pituitary hormone secretion or who produces the hormone from the posterior pituitary, it's different. In the anterior pituitary, again, the one that produces the hormone are the epithelial cells that I have mentioned a while ago. In your posterior pituitary, it is actually, if you can still remember, the magnocellular neuron of your paraventricular nucleus for your oxytocin and your supraoptic nucleus for your ADH. Okay? So meaning to say that in your posterior pituitary, the one that synthesizes the hormone are the ones coming from the hypothalamus. Okay? Sa anterior pituitary, yung epithelial cells, dito sa posterior pituitary, it's either the paraventricular nucleus or the supraoptic nucleus. Okay? Again, differentiation or second differentiation. The second differentiation is how will you now release the hormone from the anterior pituitary, and then how will you release the hormone from the posterior pituitary? We know for a fact, according to Dr. Valerio's lecture this morning again, for you to be able to secrete the hormone coming from your anterior pituitary, you have to have a hormone, either an inhibitory or a releasing hormone coming from the hypothalamus. Correct? Galing sa hypothalamus yung stimulation going to the anterior pituitary. Now, once the anterior pituitary gland is stimulated, i-release niya na yung anim. Okay? But if you're talking about the secretion of hormone from your posterior pituitary, you do not need any hypothalamic inhibitory or any hypothalamic releasing hormone. You only need a direct neural control, secondary to the stimulation. Okay? So once there is a stimulation, what happens is either your oxytocin or your ADH will go to this neurophysin. Neurophysin is actually the carrier. And it goes down directly from the hypothalamus. And there it goes. Okay? Meaning to say, once it's secreted from the hypothalamus to once it is secreted from the posterior pituitary, the different physiological effects of that hormone now can happen. Okay? So again, secretion from the anterior pituitary is via this one, and then posterior pituitary via direct nerve control or direct nerve signal. Okay? Now, again, looking at this picture, no, this is the anterior pituitary and this is the posterior pituitary. Again, if you look at closely, the posterior pituitary has a direct connection in the hypothalamus as compared to the anterior pituitary. The anterior pituitary, the connection of that to the hypothalamus is only via this hypophyseal portal vein. Ito, yung dalawang blue na line. Kaya nga po, kailangan natin ng hypothalamic releasing or inhibitory hormone for you to stimulate the secretion of the anterior pituitary hormone. Whereas if you're talking about the posterior pituitary, since it has a direct connection in the hypothalamus, you only need a direct neural control or direct stimulus. Now, my question is, what if, for example, we try to excise the gland? Okay, although in reality, whenever there will be tumors involving the pituitary, it's very hard for the surgeon to actually access and excise the pituitary gland simply because it's located at the middle, no? Nandun siya sa may sphenoid bone nyo, dun sa may sella turcica. So most often than not, the treatment for patients with a pituitary tumor is through radiation, irradiation lang. Hindi nila masyadong na-access yan. But what if, for example, a patient has been hypophysectomized? No? That's the medical term for the removal of the pituitary. And we remove the pituitary at this part. Okay? What do you think might happen to the secretion of the hormone? Anybody? If, for example, you remove that on the red line, tinanggal mo, so wala na yan. What do you think now will be the secretion? Anybody? What do you think will happen to the secretion of the hormone? Can I hear from Dr. Samantha Ann Carmesis? What do you think might happen to the secretion of the hormone?
It will decrease po.
It will decrease, particularly what hormones? Particularly what hormone, Doctora? Can I hear from Kimberly May Briones? What particular hormone secretion will decrease? Is it the anterior side, the posterior side, or both?
Both po po, Doc.
Are you asking me? I'm the one
Both.
asking you, Doctora. Why both? Why both? Yes, definitely, the secretion of the hormone after the removal of the pituitary gland will decrease. But look at again the picture. What will happen next? Can I hear from Angela Decano? What will happen next? What do you think will happen next? Definitely the secretion will decrease. What do you think will happen next? Kasi gustong-gusto ko nagtatawag ng mga hindi naka-on yung camera eh. Doktora Kakapit, Mary Grace. What do you think will happen next to the secretion of the hormone? Definitely at first, the hormones will decrease. But what will happen next after quite some time? If you try to look at and analyze the picture. Anybody? So you're correct, but mayroong karugtong yon. Definitely, the secretion of the hormone will decrease, correct? Because you cut the connection of the anterior pituitary from the hypothalamus, okay? That is true to all hormones coming from the adenohypophysis, okay? But if you try to look at closely the picture, what can you see? The posterior hypothalamus has the posterior pituitary has a direct connection in the hypothalamus. Correct? So as even if you try to cut it, at some point in time, the secretion of the two hormones from the neurohypophysis will decrease. But since you did not cut at the upper part of the infundibular stalk, magkakaroon pa rin yan ng growth. So meaning to say, when you're talking about the posterior pituitary hormone secretion, at first it will decrease, but at some point in time, there will now a secretion kasi magkakaroon ulit ng growth at this part. Okay? So meaning to say, the secretion of the hormone from the neurohypophysis is not that affected as compared to the hormone secretion coming from your adenohypophysis. Are you still with me? Okay? Maliwanag po tayo doon. Now, again, these are the different hypothalamic releasing and hypothalamic inhibitory hormones. Okay, so the ones that are color red are the secretions coming from the anterior pituitary, and the ones that are colored black are the hormones that increases or decreases the secretion of your anterior pituitary, and this came from your hypothalamus. Okay? So again, secretion of the hormone in your adenohypophysis, you have 3 levels, if you can still remember. You have the hypothalamic, which is the highest, anterior pituitary, down to the peripheral target gland. And please remember that it's not the anterior pituitary hormone that gives the different physiological effects of the body. It is the effect of the hormone secreted from the peripheral endocrine gland. Okay? Except for the hormone prolactin and growth, and the hormone somatotropin or your growth hormone. Okay? Now, when you're talking about the anterior pituitary gland, again, you have different peripheral target gland. Okay? One hormone which is not connected with this type or endocrine axis is actually your hormone prolactin. Hindi siya kasama sa endocrine. From the word itself, endocrine axis. Simply because your hormone prolactin, the target cells are not actually glands or an endocrine glands. They are the breast. And the breast is not an endocrine organ. Okay? So, hindi siya kasama sa endocrine axis, yung prolactin. Okay? Maliwanag tayo dyan, ha? Now, Dr. Valerio mentioned also a while ago the hierarchy of the disorder. It can either be tertiary, secondary, or primary type of disorder. Tertiary, hypothalamus, secondary, anterior pituitary, and primary if you're dealing with a disorder coming from the peripheral target gland. And which among will give you the more severe type of disorder among the hierarchy? Sino yung pinakapangit? Is it the primary, secondary, or tertiary type of disorder? What do you think? Yung primary. Because again, your primary is the one that gives a different human physiological effects. Okay? Now, another disorder, when you're talking about the pituitary, can be subdivided into either mild, moderate, and severe. Okay? Simply because if you can still remember, mild, TSH lang ang may problema. Bakit? Because your thyrotropes or the ones that secretes your TSH are the least number of cells that are found in the adenohypophysis. Okay? Moderate to severe, kapag may kasama ka ng FSH and LH. Okay? Sorry. So mild kasi, thyrotropes 5% lang. Moderate kapag kasama na yung gonadotropes and corticotropes. And markedly severe pag all of the hormones are affected. Okay? Maliwanag tayo doon. So it's either primary, secondary, or tertiary, or mild, markedly severe, and moderate. Okay? Now, let's now go to the anterior pituitary hormones. Again, you have 6. ACTH is a part of your pituitary hormone that will be discussed to you in details after your thyroid physiology. Okay? So just a tip of the iceberg, when you're talking about your ACTH, it has a diurnal pattern that peaks early in the morning and valleys late in the afternoon. And these are the different regulators of your ACTH. Again, this is part of your endocrine axis. So hypothalamic, pituitary, adrenal axis. Okay? The target gland is your adrenal cortex, and that is the one that releases your hormone cortisol. And when you're talking about ACTH, it helps the cortisol to secrete and gives the different effect in the metabolism of your glucose, fat, and protein. But then again, these are just the tip of the iceberg because again, that will be discussed to you in details. You will also meet that your ACTH or your cortisol has an anti-inflammatory effect. That's why it is also called as an anti-inflammatory hormone. Okay? Now, let's go to the second hormone, thyrotropin. When you're talking about thyrotropin, you're talking about the hormone TSH, and the peripheral target gland is your thyroid that will secrete the T3 and T4. Your thyrotropin or your TSH is one of the 3 glycoprotein hormone. Okay? What are the other 2 glycoprotein hormone where your TSH belongs? The 2 other glycoprotein hormone are your FSH and your LH. No, kaya po glycoprotein hormone ang tawag sa kanila because they have a common alpha subunit. But what makes them different from each other is the beta subunit. Okay? So what will now be the clinical correlation of that? It just means to say that if one is increased among these three glycoprotein hormone, the others can be also affected. Okay? My common example is, for example, me and I have two other female siblings. Our common subunit, alpha subunit, is our surname, Magpale. But what makes me different from my other sibling is that my name is Sheila, the other is Mary Rose, and the other is Katrina. But since we have a heredofamilial disease, which is diabetes mellitus, if I will get a diabetes mellitus, more likely my other siblings will also have. Okay? Another example, if for example you have problems in the secretion of your thyroid hormone, your T3 and T4, either a decrease or increase in secretion, mataas or mababa, the two other glycoprotein hormone might be affected. And if the patient is a female patient, more likely that female patient might have problems in their menses. Simply because the one that regulates your menses are your hormone, estrogen and progesterone, and that is in the help of your FSH and LH. The secretion of your two steroid hormone is via this two stimulatory hormone coming from the anterior pituitary towards your ovary. Okay? Now, again, since this is a hypothalamic endocrine axis, you have the secretion of your TRH coming from the hypothalamus that will secrete the anterior pituitary TSH, and then that will now stimulate the thyroid gland to secrete now your T3 and T4. And just the tip of the iceberg again, when you're talking about your thyroid hormone, it controls the rate of most of the intracellular reactions inside the body. Okay? So this is just the same picture. Now, again, that will be discussed to you in details as well as the gonadal axis. When you're talking about the gonadal axis, you're talking about the secretion of your hormone, FSH and LH. Okay? So, na-discuss na natin ng konti yung ACTH and your TSH. Now, let's go to the discussion of your FSH and LH. When you're talking about FSH and LH, there are two target organs. It's either testis for males or ovary for females. Okay? The secretion of your FSH and LH depends on a hormone, again, coming from the hypothalamus, known as your gonadotropin-releasing hormone or your luteinizing hormone releasing hormone. So without these two, there will be no secretion of your FSH and LH. So depende again, if your patient is a male, then therefore, the target organ is testis. And that will secrete your hormone testosterone and inhibin. And if your target gland is ovary because your patient is a female, therefore, these are the different hormones that it will secrete. Now, when you're talking about the gonadal axis, again, you have to have a releasing hormone coming from the hypothalamus. Now, you call it as your gonadotropin releasing hormone. And again, it should be secreted in a pulsatile manner, pabugso-bugso. Because there was a study wherein there was a continuous infusion of the GnRH. What happens is, it downregulates the receptor. So once it downregulates the receptor, what do you think will happen to the secretion of LH and FSH? Syempre, bababa. Okay? So again, it should be pulsatile. Now, your GnRH, aside from it came from the hypothalamus to stimulate the anterior pituitary to release these two hormones, you can also give the GnRH as a medication to a specific patient. Okay? And we in OBGYN side, we actually give this GnRH as a therapy or medication to gynecologic patients. Meaning to say, mga pasyente na may problema, for example, on their menses, or for example, there is a tumor known as myoma. But GnRH is very expensive, so not all patients with abnormalities in the menses or with a tumor known as myoma is given GnRH. Okay? Example, yung pasyente, we really need her to give we really need the medication GnRH to stop her menses. What we do is to get that medication and inject the GnRH intramuscularly or subcutaneously. And what will happen to that patient? Since you gave the GnRH continuously via bolus dose, it now saturates this LH and FSH. So, anong mangyayari dun sa pasyente na nag-a-abnormal ang bleeding? If you give a bolus dose of GnRH, therefore, it downregulates the receptors, hindi na magre-regla yung patient mo. So, the bleeding will stop. Okay? So, that's how the medication works and that's how your GnRH works. Again, it should be given in a continuous infusion if you want to downregulate the receptors. But physiologically speaking, your GnRH should be secreted in a pulsatile manner for the LH and FSH to be secreted. Okay? Now, in your hypothalamic pituitary testis axis, this is if you're talking about male patients. No? FSH has something to do with the hormones, with the spermatogenesis, and your LH has something to do with your testosterone secretion. Now, if for example, you downregulated the hormones from above, GnRH, what will now happen to a patient with a decrease in the secretion of FSH and LH? Ano kaya magiging complaint ng pasyente? Pag walang FSH and LH, you're talking about a male patient. What do you think will happen? Common complaint. By just looking at the picture. Yes. Go ahead, Doc.
Erectile dysfunction po.
Erectile dysfunction, and you call it as impotence because you have decrease in your testosterone secretion. What else? Ano pa kaya? Walang sperm. So meaning to say, because there will be no spermatogenesis, because FSH is also decreased, patient will also be infertile. Ano pa? Impotence is different from infertility. Okay? Because when you say impotence is the problem in penile erection alone. Okay? But when you say infertility has many factors. It's either the patient is infertile because the patient is impotent, or the patient is infertile because there is a decrease in the number of sperm. So, ibig sabihin, not all infertile patient is impotent. Kasi hindi naman lahat nagkakaroon ng erectile dysfunction. Some still has erection, penile erection, pero may sperm, pero konti lang yung sperm na lumalabas. Okay? So, I want you to be corrected. So, not all infertile patient is impotent because impotency is the decrease or no penile erection. What else? So, infertility, impotence, another is decrease in the secondary sexual characteristic if this will happen in a patient who is on his puberty or pubertal age. Okay? Now, same goes true with the female patient. Female patient has something to do, pag sa lalaki, FSH, spermatogenesis. Pag sa babae, oocyte maturation. And for your development of your sex steroid hormone known as your estrogen. Another is your LH. LH sa lalaki, testosterone secretion. Sa babae, progesterone secretion. Now, going back, what now will happen if you try to decrease or if you try to downregulate the receptor? So these two hormones will decrease in the secretion. So there will be no stimulation in the ovary. What do you think now will happen to the female patient naman? Female patient will have?
Amenorrhea po.
Amenorrhea, correct. There will be problems in her menses. What else? Amenorrhea, parehas ng lalaki. Secondary sexual characteristic, and since the patient has amenorrhea, patient might also have problems in her fertility. So there will be also infertility problem. Okay? Maliwanag tayo doon. Again, the 4 other hormones will be discussed to you in details in your subsequent lecture. Now, let's go in details with the growth hormone. When you hear the word growth hormone, ang unang pumapasok sa inyo ay yan yung hormone na nagpapatangkad. Correct? Kapag naririnig niyo siya. And some of the patients are actually insecure about their height. And they will end up, kapag medyo may pera sila, they will end up buying the ones that are advertised in the television, telling them that if you try to drink this, then tatangkad ka. The growth hormone supplements. Okay? But later on, you will realize that that product does not actually give an additional height. Okay? Because once the epiphyseal plate is already closed, wala nang pag-asa. Okay? Hindi na kayo tatangkad. Now, your growth hormone is also known as your somatotropin. Okay? Again, coming from the hypothalamus, either an inhibitory or releasing hormone, you have your growth hormone releasing hormone that stimulates your anterior pituitary to release your growth hormone. And the one that inhibits the secretion is your somatostatin. Okay? Please do not mistake the words somatostatin, somatotropin, and your somatomedin C. When you say somatostatin, that is the hormone that comes from the hypothalamus that inhibits the secretion of your somatotropin or your growth hormone. When you say somatotropin, that is the growth hormone. Okay? And when you say somatomedin C, that is a hormone secreted in the liver secondary to the effect of your somatotropin. Okay? Again, I think this was mentioned by Dr. Valerio a while ago that when you're talking about growth hormone, ano ba yung mga target cells niya? All the cells that are capable of growing. Okay? Now, growth hormone, again, is also known as your somatotropin or your somatotropic hormone. Okay? Plasma level is higher in infants and children than in adults. Again, it has a diurnal pattern and the secretion is also pulsatile. Okay? Now, even if we are already adults, we can still secrete growth hormone. And the secretion of growth hormone during adulthood is actually to lessen the effects of aging. Okay? Now, this is a graph showing you that as we age, the growth hormone secretion declines. Okay? So meaning to say, even your lolos or your lolas still secretes growth hormone. But the quantity of the growth hormone that they secrete is a little small na. Okay? Now, what is the significance of your growth hormone during adulthood? This actually prevents the sign of aging. Because one of the effect of your growth hormone is actually for muscle build-up. And again, just by merely looking at this picture, it means to say that as they age or as we age, no, as the patient grows on senile age, what will usually happen to the growth of their muscle? Anong itsura? Di ba if you'll see a patient who is around 85 to 90 years old, kung may mga lolo-lola pa kayo, even if they eat a lot, di ba? Ang itsura ng katawan nila parang skin and bone na lang. Tama? Mapapayat na lang sila. Simply because there is no growth hormone secretion na or a little na lang yung growth hormone secretion. If you try to read your book, your Guyton, there was a study about the effects of your growth hormone and the effects of your growth hormone in aging. 2 patients was seen of the same age, around 50 years old. One looks like a regular 50 years old, but another 50 years old looks like parang mga 80 or 90 years old na sila. What they did was to get the levels of the growth hormone to that same patient. And they knew that the patient na 50 years old pero ang itsura na niya sobrang tanda, masyadong mababa na yung growth hormone sa katawan. So that's the effect of your growth hormone. So even if we're already adult, we still need growth hormone. And that is to prevent the effects of aging. Okay? Now, again, these are the different target organs of your growth hormone. What now stimulates your growth hormone? Okay? So these are the one that stimulates them. Decreased blood glucose, free fatty acids, and starvation. There is a hormone in the stomach known as ghrelin. Okay? So ghrelin is actually released in the stomach in response to starvation and fasting. And this actually stimulates the hormone ghrelin, once it's released in the stomach during fasting, stimulates the growth hormone secretion. Okay? Another stimulus for your growth hormone is your testosterone and your estrogen. And when do you expect testosterone and estrogen to stimulate growth hormone secretion? Simply, the answer is during puberty. Okay? Because during puberty, what will happen? Mag-on na naman yung brain nyo to stimulate testosterone and estrogen. Now, once testosterone and estrogen is stimulated during puberty, you will now have what you so-called as growth spurt. Kaya nga minsan, kapag umalis yung mga uncles nyo or yung mga mas matatanda sa inyo and then they come back after few years, ano yung sinasabi? Ay, ang laki na nung anak mo. Or kaya bigla kang tumangka, dati ang liit-liit mo pa. Okay? And that is the effect of your hormone testosterone and estrogen during puberty to stimulate the release of your somatotropin. Okay? Another stimulus for your growth hormone is deep sleep, and that is during your REM sleep. Okay? And this is the scientific basis for your yaya, your mom, and your lola telling you to sleep during siesta time so that you will grow. Diba? Tulog ka, mag-siesta ka para tumangkad ka. Actually, it has a scientific basis because again, during deep sleep is where your growth hormone is secreted. When do you know the patient or that infant or that toddler is already in deep sleep? Kapag may mga kapatid kayong mas bata, tingnan nyo pag natutulog sila, the eyeballs usually turns from right to left. Nakapikit, tapos yung eyeballs makikita nyo gumagalaw. Okay? That's already the REM sleep, rapid eye movement sleep. At kapag nag-rapid eye movement na sila, that's the time that the growth hormone is being secreted. Huwag nyo silang guguluhin. Okay? Let them sleep and let them nourish the secretion of your growth hormone, their growth hormone. Okay? So again, stimulus is from the hypothalamus, your growth hormone releasing hormone. And these are the ones that inhibits your growth hormone secretion. One of it is actually obesity. That's why if you see most of the patients who are matataba, no, they are shorter, and they are stout. Okay? Because again, obesity inhibits your growth hormone secretion. Okay? Others are your aging, again, opposite of what stimulates that. And your hormone somatomidine. Your somatomidine, again, will be discussed later. And you call it also as your insulin-like growth factor. Okay? So this is a graph telling you that during strenuous exercise and sleep, particularly deep sleep, your growth hormone is being secreted. But then again, since you're already adult, once your epiphyseal plate is already closed, kahit matulog ka maghapon, mag-exercise ka sa anytime fitness, ano ba yun? Anytime fitness, di ba? 24/7, hindi na kayo tatangkad. Okay? Because that's the end. Once your epiphyseal plate is already closed. Now, doktora, kanina ka pa lecture, asa na yung pangpatangkad? Later on, you will realize that it's not actually the effect of the direct effect of the growth hormone that will give you the maximum linear growth. It's actually the effect of your insulin-like growth factor 1 or your somatomidine C. These are the different effects of your growth hormone. It has an anabolic effect. This is what I am telling you. And the anabolic effect is the one that facilitates the transport of amino acid. Therefore, it is the one that gives the body our muscle. Okay? Muscle build up. Another effect is your ketogenic effect and a diabetogenic effect. That's why your growth hormone is also known as a diabetogenic hormone because it has an anti-insulin effect. But these two, ketogenic and diabetogenic effect, only happens if there is an excessive secretion of your growth hormone. Definitely, if the growth hormone secretion is normal, the two effect will not happen. Okay? Ito lang, anabolic lang. Okay? Now, if for example, there is an excessive secretion of your growth hormone, kailan po ba nangyayari yon? Siyempre, kapag may tumor that oversecretes your somatotropin, what will happen to the patient? That patient aside from the fact that there will be an additional increase in height, if that happens during puberty, magiging giant sila. That particular patient might also end up having full-blown diabetes mellitus. Okay, because it decreases the glucose uptake inside the tissue. What is the effect, or what will happen if the glucose will not go inside the cell because of the effect of your growth hormone? What will you think will happen? Ano mangyayari kapag hindi makapasok si glucose sa loob? What is the reason why glucose should come inside the cell? It's the energy of the cell, correct? Now, in excess of the growth hormone, what happens is it prevents the glucose to come inside the cell. So what will now happen? What do you think will happen? If the glucose cannot enter the cell, what do you think will happen now? What will now be the source of energy? The source of energy will become the free fatty acid or the fats, no? Magkakaroon sila ng gluconeogenesis, meaning to say they want to get glucose from they want to get energy from non-glucose source. And what they use is your free fatty acid. So if you can still remember back in your biochemistry, excessive free fatty acid utilization builds up acetoacetic acid in the liver. Therefore, patient will end up having ketosis. So meaning to say, a patient developing an excessive growth hormone secretion secondary to a tumor that happens during puberty, patient will end up having excessive free fatty acid utilization. So magkakaroon siya ng ketosis, a full-blown diabetes mellitus, and patient will have excessive linear growth. And you call it as gigantism. Okay? So aside from the anabolic, ketogenic, and diabetogenic effect, another direct action of your growth hormone is to stimulate the liver to produce this insulin-like growth factor 1 or your somatomedin C. Ano naman, doktora, yung somatomedin C? Okay, kanina, direct actions, metabolic actions. This one, the liver to produce your somatomedin C, it is the one that has a potent effect in increasing all aspects in human bone growth. So meaning to say, the effect of your growth hormone in the liver that produces your insulin-like growth factor 1 is the one involved for you to produce linear bone growth. Okay? So these are the effects of your insulin-like growth factor 1. Increasing protein synthesis in your chondrocyte. This is for the linear bone growth. Increasing protein synthesis in the muscle, and this is to increase your body mass, and increasing protein synthesis in most organs. Thereby, you increase the organ size. Between your growth hormone and your insulin-like growth factor 1, it's the insulin-like growth factor 1 that gives you the maximum additional height. Simply because the insulin-like growth factor 1, the half-life of that is longer than your growth hormone. Once your growth hormone is secreted, nawawala na yan after 20 minutes. Kaya nga pagka nagkaroon ka ng growth hormone secretion, you can still have a height. But the maximum height cannot be achieved without the effect of your insulin-like growth factor 1. Because the half-life of your insulin-like growth factor 1 is longer. Okay? Kaya ito yung magiging effect niya. Now, again, direct actions of your insulin-like growth factor 1 and your growth hormone. So, aside from your diabetogenic and ketogenic effect and your anabolic effect, your growth hormone has a little of the FFACL effect. But then again, the maximum will be achieved if your liver produces your insulin-like growth factor 1. Okay? Now, aside from that, it also has a sodium retention effect. Okay? So, insulin-like growth factor 1, again, it is the hormone. Your insulin-like growth factor 1 is also known as your somatomedin C. So, this is the hormone that is needed for you to achieve the maximum height. Okay? Because it has the effect on all aspects of human bone growth. Okay? Now, aside from your somatostatin, we have actually three other hormones or two other hormones that is needed for human bone growth. One is your T3 and T4 or your thyroid hormone. Kailan po ba siya importante? Importante siya during the time that you are still inside your mother's uterus. Pinagbubuntis ka pa lang. Up until you were born and during your toddler years. And this is true because if, for example, there will be problems in the thyroid function or production of your thyroid hormone during the time that the baby is still inside the womb of her mom, there is what you so-called as a pathology known as your congenital hypothyroidism. And if that fetus will develop congenital hypothyroidism, that fetus can develop cretinism. Cretinism is actually type of a dwarfism secondary to the decrease in the secretion of your T3 and T4 during fetus or fetal age. And that will be discussed to you in details next topic or next week, thyroid physiology. Another hormone, again, ito yung kanina lang na diniscuss natin, your somatotropin. And when is your somatotropin important? Siyempre, pagkapanganak mo at during your early childhood up to your early adulthood stage. Another hormone important is your testosterone or your androgen and your estrogen. And that is important during the time of your puberty. Okay? So these are the three important hormones in your human bone growth. No? Not just your somatotropin. Okay? From this point, do you have a question? Question. So again, I would like to emphasize that it's not the direct action of your growth hormone that will give you the maximum effect of your linear bone growth. It's the insulin-like growth factor 1 or your somatomedin C. Okay? Now, let's now go to the deficiency of your growth hormone. The deficiency of your growth hormone is also known as your dwarfism. Okay? So dwarfism happens if ever there will be a decrease in the growth hormone secretion. And what is the most common reason for this is, again, a problem in the tumor developing in the pituitary gland. No? Once a tumor is developed in the pituitary gland, it is also known as your panhypopituitary dwarf or panhypopituitarism. When you say pan, it involves all. So all of the anterior pituitary hormone secretion will decrease. And that will give the patient a decrease in the secretion of growth hormone, developing the dwarfism. Okay? Some of the patients do not pass puberty if you're talking about panhypopituitary dwarf simply because the secretion of your gonadotropins are also decreased. Okay? But most of the patients who has pituitary dwarfism only involves the secretion of your growth hormone alone. Ibig sabihin, most of the patients developing dwarfism, ang problema lang niya is the secretion of the growth hormone. So what will happen to the patient is they can still procreate. Kasi growth hormone lang ang problem. Okay? Now, if you're talking about pituitary dwarf, we call it as beautiful dwarf. Why? Because they are well proportional. This is different dwarfism from that of the ghoul who is an actor in Channel 2. Do you know the ghoul? The actor in Channel 2, if you try to look at the ghoul physically, he has an adult head, correct? And then the limbs are very small. The ghoul is not actually a pituitary dwarf. That is achondroplasia. Achondroplasia is a skeletal problem disorder during fetal life. Ibig sabihin, nagkaroon ng problem sa development ng bones ni the ghoul during fetal life, but not actually a pituitary dwarfism. Because if you're talking about pituitary dwarfism, the most common pituitary dwarf that most of us knew is Mahal. Kilala niyo ba si Mahal? Naabutan niyo ba si Mahal? Yung actress na maliit, tas pag nagsalita, ay hindi naman. Yung para siyang maliit na tao. If you can see, Mahal is actually a pituitary dwarf because she is well proportional. Okay? So that's how you differentiate the two. One is achondroplasia and another is the pituitary dwarf. So again, pituitary dwarfism, this is a well-proportional dwarf. And they are beautiful dwarf because again, they are well-proportional. Again, as compared to a patient who will develop cretinism. So this is actually only puberty. Pubertal lang to. But if you try to look at her face, no, there is an increase, tag nito, parang age na siya, parang aging na siya. This is actually cretinism, secondary to a decrease in the hormone secretion of your T3 and T4 during fetal life. So this is why I am emphasizing that again, one of the important hormone for bone growth or human growth is actually T3 and T4. Okay? Now, another type of dwarfism are dwarfism secondary to other endocrine disorder. Look at what Laron dwarfism is. You have a growth hormone insensitivity due to a genetic defect in the receptor and a marked decrease in the insulin-like growth factor 1. That's why they develop dwarfism. This Laron dwarfism is secondary to the problems in the receptor. Therefore, Laron dwarfism cannot be corrected by growth hormone. Okay? Question, Doktora, ang growth hormone po ba available? Yes, it's available pero very expensive. And seldom can we get growth hormone kasi mahirap yan i-extract. Okay? Now, some dwarfism can be corrected if diagnosed early. Okay? But this type of dwarfism, you cannot simply correct that. It's because the problem mainly is in the receptors. No? Even if you give growth hormone, since there is a problem in the receptors, therefore it will not work. Okay? Another example of your dwarfism are your African pygmies. You'll see, the rate of your growth hormone secretion is normal, but IGF fails to increase at the time of puberty. So meaning to say, di ba yan yung mga African people, you see them in the National Geographic's channel, maliliit lang sila. Di ba? They still secreted the growth hormone. But during puberty, walang IGF production. This is what I'm telling you. That's why IGF production is very important because the growth of bones depends on the IGF-1 production. Okay? So another disorders in your dwarfism are your glucocorticoid excess and cretinism, and that will be discussed to you in details on your subsequent topic. Okay? Now, if you have a decrease in the secretion and you call it as dwarfism, we have now naman the excess. The excess, you actually call them as either gigantism or acromegaly. What do you think is the difference between the two? Gigantism and acromegaly. What is the difference? The age, no? The age of onset. If there will be an excessive secretion that happens in the young during the epiphyseal plate na open pa during puberty, you call it as gigantism. But once the epiphyseal plate is already closed and you have an excessive secretion of your growth hormone, you now call it as acromegaly. So acromegaly is for adult. Gigantism is during puberty. And just as what I told you a while ago, what are the metabolic effects of your growth hormone? Anabolic, diabetogenic, and ketogenic effect, correct? So aside from being giant, if it happens in the young, that patient might also have a full-blown diabetes mellitus, and aside from that, ketosis will also happen. Okay? Now, this is just an example of a patient developing an excessive growth hormone secreting tumor. Okay? So this is of the same age pero siya yung may tumor. So sobrang tangkad. Okay? So gigantism as we call it. Now, another excess growth hormone secretion is your acromegaly, and this happens during adulthood. And this is secondary to actually an acidophilic tumor that occurs again after adolescent, after the epiphyseal plate has already been closed. So what do you think will happen now to a patient with an acromegaly? Hindi na siya tatangkad, definitely, because the epiphyseal plate is already closed. But the ones that are affected are actually the membranous bones. Specifically, the membranous bones of the face, the hands, and the feet. Okay? So, hindi na pataas, palapad na ang bone development nila. And if you see, patients will have coarse facial features simply because the membranous bones of the face are affected. So even if they are very handsome or beautiful prior to the development of the pituitary tumor that secretes excessive somatotropin, after this phenomenon or after the physiologic effect of that, they will have coarser facial features. So medyo papangit sila ng konti. Okay? So this slide just tells us the different effects or the different clinical manifestation of a patient with acromegaly. Part of it is actually galactorrhea and sexual dysfunction. Bakit, doktora, kasali ang galactorrhea, prolactin, and sexual dysfunction? Bakit kaya? What do you think is the reason? Why, aside from the different things that we have discussed a while ago, enlargement and everything, why is sexual dysfunction and galactorrhea kasama? Galactorrhea na lang. Mamaya na yung sexual dysfunction. Why do you think galactorrhea can be present in a patient with acromegaly? Same goes true actually with a patient who is affected with gigantism. Why do you think? Increase in production kasi, you're correct, increase ng production ng ano. Because if you can still remember, sige, go ahead. Ng prolactin. Simply because both your prolactin and your somatotropin belongs to the acidophilic type of cell. Correct? Pareha silang acidophilic cell. So, more likely the reason why patients with acromegaly develops galactorrhea, it's because it's an acidophilic type of cell. So, affected din siya. Okay? So, this is an example of a picture with a female patient developing acromegaly. So, they develop a coarser facial feature. Okay? Another example, before and after. Okay? So, they develop a coarser facial feature. In short, para silang nagiging si Frankenstein. Okay? Because most of the bones affected are the membranous bones of the face. Okay? So, that is the two disorder. You have a decrease in the growth hormone secretion and excessive. Dwarfism, excessive naman, acromegaly in adult, and gigantism for puberty. At this point, do you have questions? Tatlong hormone na lang. I know you feel saturated because I can see your faces in the video. I was also saturated because I was also listening with Dr. Valerio. No, even if I know the topic, I was trying to listen to her pero nakakaano na siya. Okay? Konti na lang mga bakla. Okay? Again, sorry. If I call you bakla, it's just my call of endearment to everybody. Alam yan ng buong ospital. Okay? So pagka lalaki ka and then I accidentally called you bakla, I do not mean anything with that. It's just my call of endearment. Okay? Now, let's now go to the last hormone in the anterior pituitary. Last is your prolactin. Okay? Again, prolactin does not belong to the pituitary endocrine axis simply because the target gland of your prolactin are the breast. And the breast is not an endocrine organ. Okay? Now, your prolactin is the one actually that increases the mammary gland during pregnancy. And that is in preparation for breastfeeding. And aside from that, your prolactin also has something to do with the milk production. So milk production and mammary gland development. So what are the factors that increases your prolactin secretion? The number one is actually breastfeeding. Because the most important or most significant actions of your prolactin happens after the patient delivered. Ibig sabihin, pagkatapos ng pasyente manganak, no? Especially for the first time, second time, or yung mga mommy natin around. But then again, ang prolactin is not just limited to female patients because excessive prolactin secretion can also happen to male patients. Now, number one factor that increases your prolactin secretion is breastfeeding. And this is important for patient who just gave birth. No? Pagka may mga pasyente kasing nanganganak, minsan may mga nanganganak na pasyente, nanganak ngayon. Bukas magtatanong, Doktora, ba't wala pa akong milk production? Okay, bakit hindi ko pa po mapa-breastfeed yung baby ko? Ba't wala pa pong lumalabas na gatas? Ang sagot po dyan is they have to stimulate the production of prolactin. And how will we stimulate the production of prolactin? To stimulate that. And to ask the mother to breastfeed kahit na wala pang lumalabas. It's because without stimulation, your prolactin secretion will not happen. Okay? And again, what we always tell the patient who just delivered is patience is a virtue. Hindi lumalabas agad ang milk. Or there will definitely no milk production within 24 hours for most of the patient. Yung iba gifted meron na, but most of the patients wala pa. So what you will tell them is to stimulate that. Okay? So another factor that increases your prolactin secretion is through this dopamine antagonist. No, your hypothalamus actually antagonizes the effect of dopamine, and once it antagonizes the effect of dopamine, that actually promotes your prolactin secretion. And aside from that, the three others are the one that stimulates the production of your prolactin. Now, these are the factors naman that decreases your prolactin secretion. One of it is actually a medication that we give to patient who doesn't anymore want to breastfeed. And that is in the form of your bromkriptine. Okay? Bromkriptine is actually a medication that we can give to patients who do not anymore want to breastfeed. Kasi for example, nanganak sila, they only have 105 days to be exact na pwede silang mag-leave. Okay? We call it maternity leave. After 3 months, no, they have to go back to their work. And some of the patients do not actually want to express their milk during the time na nasa office sila. Doktora, ayoko na po magpa-breastfeed pero sobra po ang stimulation ng breast ko, laging may milk. So what we give is actually bromkriptine. Okay? So that can inhibit the milk production, bromkriptine. Now, let's now go to the actions of your prolactin since alam nyo na ang factors that can increase and decrease the secretion. One action of your prolactin, again, is for milk production or lactogenesis. Now, another actions of your prolactin is to increase your prolactin and increase your dopamine, and thereby the effect will be inhibit the ovulation. What do you think now is the significance of the number 2 action of your prolactin? Increasing the prolactin, increasing the dopamine, it now downregulates or decreases your gonadotropin releasing hormone. Thereby, there will be decrease or inhibiting. It inhibits ovulation. What do you think now is the effect of that? The number 2. Try to clinically correlate that. A patient who just gave birth, exclusively breastfeeding. What do you think will happen to the patient? Mga bakla. Mga bakla, tas walang sasagot na lalaki kasi ayaw nilang matawag ko silang bakla. Ang mga kapatid, what do you think will happen to the patient? Action number 2, inhibit ovulation. So simply, a patient who is breastfeeding will have problems in their Paulo. Kitang-kita ko yung mukha mo, parang gustong sumagot eh. Paulo Vispo.
Yes.
Chappy ka ba? Chubby ka ba? O ako lang yon? Ulit, Doc.
Since Doc in-inhibit yung ovulation, mababa yung chance to get pregnant.
Mababa yung chance to get pregnant. Very good. Simply because the GnRH is decreased during breastfeeding. That's why breastfeeding is one of the contraception that we promote after delivery. No, natural means of contraception. And we call it as lactation amenorrhea method. Okay? Meaning to say that if the patient is breastfeeding purely at that, it prevents the patient to get pregnant early. Kasi it inhibits ovulation. Aside from that, anong mangyayari sa pasyente mo? Patient will actually ask you, bakit hindi po ako nagre-regla? And simply because, again, you tried to inhibit ovulation by trying to do purely breastfeeding. Pag sinabi pong purely breastfeeding, hindi yan ngayon magpapadede yung mami, after nyan magmi-milk formula sila. Pag purely breastfeeding, puro breastfeed, walang formula feed. And the interval should be every 4 hours or more often during daytime and every 6 hours or more often during nighttime. Bakit, doktora, more often? Because you wanted to increase the secretion of prolactin para magtuloy-tuloy na ma-inhibit yung ovulation niya. Okay? Another thing that might happen is that patient who is purely breastfeeding, since the action of number 2 increases your prolactin and it also increases your dopamine, what will happen to patient is that they can also ask you, bakit hindi pa ako nagre-regla 5 months na akong nanganak? Okay? So, patient might also have amenorrhea as long as 18 months. So that is something physiologic. Okay? But still, you have to take note kasi minsan akala nila nagbe-breastfeed sila, okay na. Tapos yun pala nabuntis na kaya hindi sila nagre-regla. Okay? So you have to still rule out the presence of pregnancy. But then again, if a patient is breastfeeding purely at that will inhibit ovulation. So no pregnancy will happen. And again, there will be also presence of amenorrhea. Okay? Now, number 3, it also inhibits spermatogenesis. Because again, prolactin is not limited to female patients. Tama? Pwede naman kasing magkaroon ng tumor ang pasyente na lalaki that secretes excessive prolactin. So what will now happen to a male patient with a excessive secretion of your prolactin? Ano kayang pwedeng mangyari sa kanya? A patient with excessive secretion of prolactin. So male patient will have mammary gland development and you call it as gynecomastia, and that mammary gland can also produce milk. Okay? Pero syempre, hindi yun pwedeng ipang breastfeed. Okay? Now, what do you think will happen aside from that? Aside from the gynecomastia in mammary gland development and milk production, what other things might happen to that male patient developing excessive prolactin secretion? Kung anovulation sa babae, ano mangyayari sa lalaki? Because you also decrease GnRH, thereby you also decrease your FSH and LH secretion. What do you think will happen? Infertility. Okay? And more likely, impotence might also happen because you also decrease your LH, the production of your testosterone. Okay? So you have 2 patients. 1 patient kakapanganak. Pangalawa, lalaki. Pangatlo, paano kapag babae pero hindi siya nanganak? A single patient without sexual contact developed a pituitary tumor. What do you think will now be the clinical manifestation? Can I hear from Erica? Jazz Ann Lopez. Female patient, single at that, no sexual contact, developing prolactin secreting tumor. What do you think will happen? Doktora.
Lactation.
Hello?
Maglalactate po daw.
Maglalactate? Ano pa? So, that patient can also lactate. There will also be mammary gland development. Again, since you try to inhibit ovulation, that patient, same as the patient who just gave birth, she will have on and off amenorrhea and problems in her fertility. Okay? Maliwanag tayo doon? Saturated na kayo. I hope that's a little clear. So you have 3 different patients wherein your prolactin can have an excessive secretion. One is a breastfeeding mother, the other is a female patient who doesn't have any sexual contact, and a male patient developing a prolactin secreting tumor. So just by merely looking at the actions of your prolactin, alam mo na kung ano yung mga pwedeng mangyari. Okay? Now, what do you think will inhibit the mammary gland development and the secretion or lactogenesis, you give the patient your medication bromkriptine. Okay? Kanina, if you can still remember the bromkriptine medication. So that is the medication that we give to elevate or to inhibit the patient to lactate. Okay? So again, you have abnormalities in your prolactin, either hypoprolactinemia. Seldom do we meet this one. Okay? But the most common is hyperprolactinemia. Hyperprolactinemia, that is very good if the patient just gave birth for breastfeeding. But if the patient is a female patient, single, and a male patient developing hyperprolactinemia, that is something abnormal. Okay? So that is for your prolactin secretion. So again, mammary gland development and galactorrhea. So do you have problems or question at this point? Question? Wala? Can we now go to the posterior pituitary hormone? Okay. So posterior pituitary hormone, we only have two. No? We have your oxytocin and your ADH. This is different again from your anterior pituitary hormone because for you to be able to secrete this one is you only have to stimulate. You only have to give a direct neural control. Okay. Now, when you're talking about the posterior pituitary hormone, you only have two. You have your ADH and your vasopressin. Your ADH is also known as your vasopressin because it has two receptors. I think this was discussed to you in your renal physiology. Tama ba? Diniscuss na to ni Tito Rock. Tama? So, you have two receptors. You have the vasoconstrictive, the V1A receptor. That's why it's also known as your vasopressin. And you have the V2 receptor, which has an antidiuretic effect. In medicine, if you hear the word diuresis, ibig sabihin papaihiin mo. Okay? Diuretic, ibig sabihin pangpaihi. But this time, you're talking about an antidiuretic hormone. So meaning to say that you're trying to prevent the patient to pee. Okay? Antidiuretic hormone. So what is the significance of your vasopressin? The significance of your vasopressin is simply for water balance. And you know for a fact that the receptors are found in the collecting ducts and the distal convoluted tubules of your kidney. Okay? So what stimulates your vasopressin? Anything that increases the extracellular fluid osmolarity. Okay? Now, examples of phenomenon wherein you have an increase in the extracellular fluid osmolarity is one, during dehydration. The most common example, kailan ba nade-dehydrate ang pasyente? If, for example, a pediatric patient comes inside the emergency room, the mother complains that the patient or her infant is having bouts of loose stool, nagtatae, for example. Okay? Or ikaw, pag nagtatae ka, di ba, if you're already dehydrated, what can you feel? You feel weak. Tama? Another thing that you'll take note of is, are you still having bouts of urine? O naiihi ka pa ba? Marami pa ba ang ihi mo? Di ba hindi? Kapag nagtatai ka na at dehydrated ka na, konti na lang ang ihi mo. Simply because the ADH is stimulated. Okay? Another example, hypovolemia. Kailan ka makaka-experience ng hypovolemia? If you have a hypovolemic shock, for example, secondary to massive blood loss. May pasyente na saksak na baril sa labas, dinala sa emergency room. What will the surgery team will tell you if you're the intern in the emergency room? They will ask you to put a Foley catheter. You know what Foley catheter is? Alam niyo ba kung anong Foley catheter? Foley catheter is the one inserted at the urethra for us to be able to check if the urine output of the patient is adequate or not. Okay? Pinalagyan ng Foley catheter yung pasyente na na-gunshot wound before the operation. What do you think will be the concentration of the urine? It's usually concentrated and minute in amount. Simply because you stimulated again the ADH release secondary to that hypovolemic shock. Okay? So others are the reasons for you to be able to stimulate the posterior pituitary to release your ADH. Okay? Now, again, if you have a decreased body water, that stimulates the extracellular fluid osmolarity to go up, no? And now, it will send signal to the center to release your ADH. Therefore, what will happen is that your urine is minute in quantity and usually concentrated. Okay? Now, these are the ones that inhibits the effect naman of your ADH. Decrease in the extracellular fluid osmolarity over hydration. Di ba pag inom ka ng inom, ihi ka din ng ihi. Alcohol is actually one that inhibits your ADH. Di ba pag nag-break kayo ng jowa mo or masama loob mo kasi binagsak ka ni Dr. Valerio, iinom ka. So what do you think will happen? It inhibits the secretion of your ADH. Pag inom ka ng alcohol or ng tea or ng coffee, di ba ihi ka rin ng ihi? Cool or cold environment also decreases the secretion of your ADH. That's why in a cold environment, ihi ka din ng ihi. Okay? So it's actually the opposite. If you have a decrease in the secretion of your ADH, instead that your urine is minute and concentrated, this time, since there is a decrease in the secretion of your ADH, the urine is usually voluminous and diluted. Kabaliktaran naman siya. Okay? Now, when you're talking about ADH, if you can still remember, you have two types of disorder. One is the syndrome of inappropriate secretion of your ADH, and another is your central diabetes insipidus. When you say central diabetes insipidus, when you say diabetes insipidus, you have two. You have a central diabetes insipidus and nephrogenic diabetes insipidus. What is the difference between the two? Because both of which, the clinical manifestation will have a polyuria, polydipsia, hypotension, and a dilute urine. But one is different from the other is that because when you're talking about your central diabetes insipidus, you're talking about what? Can I hear from Dr. Marion Wood? What is the difference between a central from a nephrogenic diabetes insipidus? Konti na lang mga kapatid, isang hormone na lang pagkatapos ito. Alam kong saturated na kayo. What's the difference between central? Anong sabi sa renal physiology? Our most favorite topic.
There's no
Yes.
ADH secretion in the
There is
central.
Why, Doctora? Why do you think?
Because there's the abnormality in the posterior pituitary.
Because most probably, you're correct, Doctor. Most probably, when you're talking about central, it means to say the one that secretes the hormone. So more probably, the problem mainly is in the brain. That's why there is a decrease in the ADH secretion. What about nephrogenic, Doctora? Nephrogenic. Sige, others naman.
There's a normal or high ADH secretion.
There is a normal or high ADH secretion, but the ADH fails to produce or fails to have its effect simply because the problem is in the receptors. So between the two, which can be corrected by giving ADH? Between the two. Is it the central or the nephrogenic? Alin kaya yung pwedeng makorek?
Yung central.
Yung central. Okay? The central can be corrected, but the nephrogenic diabetes insipidus cannot be corrected by giving the patient ADH simply because in nephrogenic, the numbers or the problem mainly is in the receptors. Okay? So, the secretion of ADH in your nephrogenic is normal or high, but there is no effect simply because the problem is in the kidneys and the receptors of your ADH are found in the kidneys. But if you're talking about central diabetes insipidus, the main problem why there is a decrease in the secretion is the one that tries to secrete the hormone. The problem mainly is in the brain. So what is the clinical scenario wherein you will expect a patient to develop a central diabetes insipidus? The most common is trauma, head trauma. Okay? After an accident, there was a head trauma. The patient came into your clinic after 1 week complaining of voluminous urine. The first differential diagnosis that you will think of is a central type of diabetes insipidus. Okay? But then again, both patients' clinical manifestation would be the same. Okay? Now, another problem in your ADH secretion, yung kanina, you try to pee a lot. Tama? This time, you have syndrome of inappropriate secretion of ADH, meaning to say that the ADH secretion naman, excessive. Okay? This is secondary to actually a bronchogenic tumor or lung cancer, the most common reason for the excessive secretion of this SIADH. And the opposite of your diabetes insipidus, kanina, you try to pee a lot. This time, you have water retention because you cannot anymore pee. Secondary to the excessive secretion of your ADH. Okay, that's why the clinical features of this one is the opposite of the diabetes insipidus. Now you have water retention, you have edema. Okay, kasi hindi mo mailabas yung water. You develop hypertension because of hypervolemia, and you have now serum dilution. Okay, so that's how you differentiate the syndrome of inappropriate secretion from your diabetes insipidus. One is you try to pee a lot. This time, hindi ka naman maihi. Okay? So do you have question for your ADH? Wala? Sige. Now let's go to the last and final hormone in the posterior pituitary, and you call it as your oxytocin. Why is oxytocin called as loved hormone? Why do you think oxytocin is called the loved hormone? Anybody? Have you come across that oxytocin? Have you read that? Oxytocin is also known as loved hormone. Bakit kaya? Nabasa niyo na ba yun? Anybody?
Not released during sex.
Yes, because it's actually released during sexual intercourse. Okay, that's why it's also called as loved hormone. Teka lang ha, may question. Doc, if may tumor po always stimulates the production of the hormone, pwede rin po ba mag-downregulate ng hormone to? Yes. If you're talking about tumor, since it's an enlargement, the first thing that will happen actually is to excessively stimulate the production of that hormone. But since there is a tumor, anong nangyayari? Palaki siya ng palaki. After quite some time, that pituitary gland will be destroyed. So what will happen after the upsurge of the hormone, magda-downregulate na siya. Bababa naman. Okay, did I answer your question, Dr. Unidad?
Yes po, Doc. Thank you po.
Thank you. Now, oxytocin. Okay, so again, this is love hormone because that is usually released during coitus. Okay, and for you to be able to stimulate the secretion of your oxytocin, just like your prolactin, you have to do breastfeeding or suckling of the nipple. Okay, when you're talking about your oxytocin or your love hormone, you have actually two actions. One action is for the myoepithelial cells or the mammary gland to contract, and that is for the milk ejection. Okay? Meaning to say that for you to be able to breastfeed, the mothers to be able to breastfeed, hindi lang kailangang prolactin ang meron. Because even if you have so much production of milk, without the actions of the oxytocin, that milk cannot go out. Okay? That's why your oxytocin is also known as your milk letdown or milk ejection hormone. Okay? Aside from the action of your oxytocin in the mammary gland, it also has an action in the contraction of the uterus. One is during coitus, yun yung sinasabi nila Doc kanina, because during coitus, what happens is oxytocin is being released during coitus. It tries to contract the uterus so that it will try to facilitate the transport of sperm. That is during coitus. But the most significant action of your oxytocin in the contraction of the uterus is during pregnancy, and that is during the time that the patient is giving birth. It tries to contract the uterus for delivery or for parturition. Now, parturition is the medical term for delivery. Okay? My question, No? Again, there are two actions of your oxytocin. One is for the breast and the other is for the uterus. My question is, if the patient is breastfeeding, what do you think can happen, or what do you think can be a manifestation or a common complaint of a patient who is breastfeeding? Common complaint of a patient who is breastfeeding. What do you think?
Hypogastric pain.
Hypogastric pain. Okay, you're correct. So hypogastric pain can be a complaint in a patient who is breastfeeding simply because once oxytocin is released, aside from being the milk letdown hormone, it tries to also stimulate the contraction of the uterus. Okay? Kaya kapag may pasyente na nagbe-breastfeed at nagtanong sa inyo, bakit kaya pag nagbe-breastfeed ako, masakit din minsan or parang tumitigas yung sa may bandang puson ko? It's actually the direct actions of your oxytocin. Okay? And that is something physiologic. So again, when you're talking about your hormone oxytocin, you have to have a direct neural control, and that is to stimulate or suck the nipple of the mother to produce milk letdown. And that is actually a positive feedback loop. And aside from the mammary gland, no, it also has an effect in the contraction of the uterus. Okay? So do you have a question for your hormone oxytocin? Wala? So again, that's the last hormone. So just a review, if you're talking about the pituitary, you have the epithelial part, which is the adenohypophysis, and you have the posterior pituitary part, which is the neural part. Okay, because again, the embryonic origin is different. Synthesis of the hormone in the anterior pituitary, you have the different types of cell, acidophilic and the basophilic cell. But if you're talking about the posterior pituitary hormone secretion, it comes from the hypothalamus, either the magnocellular of your paraventricular and your supraoptic. Okay, that is for your ADH and your oxytocin. And again, for your anterior pituitary hormone secretion, you have to have an either inhibitory or stimulatory effect releasing or an inhibitory hormone coming from the hypothalamus. But in your posterior pituitary, you only have a direct neural control. Okay, 6 from the anterior pituitary, 2 from your posterior pituitary. Okay? So other hormones will be lectured to you in details. I think the next topic next week will be thyroid, to be followed by ACTH, and then female and male physiology. Okay? So do you have questions? Again, this is one of the easiest topic in your physiology. So I hope you will do good dito sa part na to. Pangbawi in Tagalog. So question? So if not, let's call it a day. I know you're saturated. I can see all your